Good afternoon, and welcome to Southcentral Foundation's first ever Nuka Fireside Chat. Thank you so much for joining us. I'm your moderator, Gil Prickett. I've been with Southcentral Foundation for 16 years and currently serve as the Senior Clinical Advisor for Learning and Development. In response to the COVID-19 pandemic, healthcare is rapidly changing, including here at SCF. In these chats, subject matter experts from Southcentral Foundation will share some lessons learned and then open it up to you for questions and comments. At the bottom of your screen, you'll see a Q&A button. Here, you'll be able to submit questions or anything else you may want to share, and I'll make sure to direct your questions to the presenters. After today's chat, we'll send you a quick survey. So please, give us your feedback so we can improve for the next chat. If you have any technical difficulty today, please email us at scfnukaevent@scf.cc, and we'll have someone reach out to you to help as we're able. Again, that email address is scfnukaevent, all one word, @scf.cc. Now, I'd like to introduce the panel for today's fireside chat. Dr. Doug Eby serves as SCF's Vice President of Medical Services. He has spent more than 20 years working in support of Alaska Native leadership, creating SCF's world-renowned Nuka system of care. He is a physician executive who has done extensive work with many organizations around the world to effect change in healthcare. Dr. Donna Galbreath serves as SCF's Senior Medical Director of Quality Assurance, providing strategic planning and development of SCF's comprehensive quality assurance program. She is Atna Athabaskan Indian. She presents nationally and internationally on quality assurance, corporate compliance, and SCF's relationship-based Nuka system of care. Michelle Aregood serves as SCF's Director of Quality Assurance. She has been at SCF for more than 13 years. Her team ensures the execution of activities that ensure SCF's quality management programs complies with local, state, and federal regulations related to accreditation, risk management, safety and security, employee health, infection control, and legal requests. And now, I turn it over to our presenters.
Hello, everyone. Thank you for joining us at this fireside chat. I want to start this off by just talking a little bit about where we're at. We're in Alaska, as you all know, but we're also very tied into the seasons here. So we are just completing harvesting fiddlehead ferns and spruce tips, and we're moving into our fishing season. So there's all sorts of fishing seasons, but right now the salmon are beginning to run, so a lot of people are out salmon fishing, and the hooligan are running, so there's lots of people out doing that also. It's definitely interesting to see. Of course, when you're fishing, you kind of naturally socially distance, but it's interesting to see people out there lined up, actually, sometimes, and they are socially distancing, but some of it has to do with catching fish. I wanted to tell you about my evening last night. I went to visit with my son and daughter-in-law, Tikon and Jen, and my grandbaby, Lyndon. And the reason I'm telling you this is because it just kind of demonstrates, as we have been slowly opening up our Alaska, opening up Alaska in general, there's lots of things that you have to consider. So we came together and we socially distanced. We ate outside, so we didn't have to worry about masks. And it was just so wonderful to be there as a family and having a good time and eating and enjoying the environment. Tikon and Jen, they grow a lot of things, so their garden was very lush around us, and they showed us the plants. And then dinner was incredible. They have done this I don't know what, they look into all sorts of things. They research things constantly. And so they have looked at different organizations and that sell food and how to get food from Alaska and how to do it in a good way. So there's something called Arctic vegetables. And so you can order all these vegetables and just drive up and get them. And the salad was incredible. It was all fresh vegetables. It was really awesome. And then we had this pasta dish, and the pasta was from Alaska Pasta Company. So that was very good. And then there was shrimp in it, and it was from Kodiak, Alaska. So every part of the meal had something to do with Alaska. Oh, and there was mushrooms too, mushrooms from Alaska. That's the other thing that's being harvested right now is mushrooms. So it was a fun time. It was a nice way to expand our bubble and to also look at our environment and to help support all of the businesses here in the state of Alaska. Now, I want to tell you a little bit about South Central. I think most of you know about South Central Foundation, but we are a vertically integrated tribal healthcare system. And we serve about 65,000 people for primary care. We also serve another 200,000 individuals as part of the Alaska Native Medical Center. We employ over 2,500 employees, and we deliver primary care, maternal child health, behavioral health, addictions, dental, and a long list of other things such as optometry, audiology, physical therapy, occupational therapy, complementary medicine, and traditional medicine. We also jointly manage ANMC with our partner, Alaska Native Tribal Health Consortium, and they employ over 3,000 employees. We are on one campus. The hospital here is 173 beds, and it has NICUs, ICUs, CCUs, infusion centers, labs, radiology, all of those parts that go into a hospital. We have all the specialty services, and we have all the surgical services also in that center. So when COVID hit Alaska, it didn't start out with a bang, and we had lots of warning because it was coming into the United States. So Alaska is isolated, and the governor chose to actually keep us isolated, and there was lots of mandates with social distancing put into place, and also around travel. People who traveled into the state were required to quarantine, and they still are actually. And so we're more like New Zealand in that way. We could actually slow the spread of COVID fairly quickly just because of how Alaska is isolated. Along those same lines, though, as we were putting all these things into place, we needed to figure out, what worked for us in our different situations here. We have a lot of villages that we serve, and they're very remote. You can only get in by plane. So the clinics are small, the staff is limited, equipment is limited, and if you have an emergency, you have to be able to get somebody out, and it is complicated. So we had to think through all those processes. In addition, our villages are tribally they're tribal organizations, and so we really work with the tribe and listen to tribal authority. So those communities did not want people coming in. They did not want COVID in their community, so they were limiting access to their communities also. And so we actually changed how we were providing care in some regards because of that. So we have providers that will travel to the villages and go back and forth, usually for a length of time, but we had them stay longer than they normally stay so that we wouldn't get travelers in and out of the village. We also had chartered planes so that, again, we aren't having a lot of people come into the community, and we also aren't having our providers stop at a lot of other communities and potentially cause more exposure. So we tried to limit exposure as much as possible. We always talked with the tribal government to let them know when we were going to switch somebody out and how we were going to do it and if they were okay with that. So a lot of work went into that. I'm going to pass this over to Doug.
Thanks, Donna. And if you could do me a favor and let TCON know I'll be over for dinner tomorrow, and maybe I can bribe my way in with a little bit of Prince William Sound shrimp or something.
I'll tell him.
Sounds fabulous. Oh, my goodness. That's good. All right. So just in terms of time management, I'm going to spend a few minutes on sort of a general overview of how the last 20 years have prepared us for what we've had to do in response to the COVID virus, especially in terms of the primary care platform and so forth. And then Donna and Michelle will add some more details of things that we've done. And all of that we expect to take another 15 or 20 minutes, and that should leave about half an hour for those of you online to ask us questions, and we'll spend the second half of the time then responding to and talking more detail to places that are topics that are of particular interest to you. From what we understand, for the people online, a lot of you know us pretty well, and we don't want to bore you with things you may already have heard 10 times. So please type into the question and answer areas, and we'll be gradually adding all those questions and then responding to those in the second half. And if you don't ask us lots of stimulating questions, we'll sit and stare at you through the screen for 30 minutes. I'm sure that'll be fascinating. Okay. It's hard without an audience that you don't get any response and feedback from. So anyway, it's been fascinating as this whole thing has happened to watch worldwide, literally worldwide, as healthcare all around the world and people we know all around the world doing healthcare improvement work have been responding to the COVID crisis. And the really great thing for us here at the Nuka system in SCF is we feel like the last 20 years of work have prepared us particularly well for the current situation. And I'll explain a little bit of what that means. We've been very centered, and we're sort of famous for the idea that we've got a customer-driven system. We refer to the people that we support as customer owners, and then really take this idea of customer ownership in all directions. Very relationship-based, seeing ourselves as a service industry rather than a manufacturing industry, and that the idea of influencing people in trusting personal relationships through shared responsibility is the platform our entire system is built upon. Well, it turns out that's perfect for what COVID has forced us to do. So as COVID has forced people in the US and all around the world to all of a sudden reorient around supporting people in their home environments, that's what we've been working on improving for 20 years. So it's exciting. I don't want to in any way to forget that COVID is terrible, and there's been much illness and death and disruption of economies, loss of jobs, huge stress on households and stability of multi-generational households and so forth. And that's all very devastating and terrible, and we try to work with our population in support of those things. But for those of us working in the improvement space around healthcare, especially trying to actually do transformation work in healthcare, this is an amazing opportunity. I'm in my early 60s now, and I kind of had given up on getting this kind of traction for things we've been working on for decades here. And all of a sudden, the entire nation and the entire world has moved our direction. So not ones to ever squander an opportunity here. We wanted to speak to exactly that and how this work we've been prioritizing for over 2 decades just has made us particularly well prepared for this COVID crisis. So relationship-based, customer ownership, virtual support, same-day access, all plays into this team-based care. Full integration of lots of different pieces of life has played really, really well for us. So long ago, we had already integrated behaviorists, dietitians, pharmacists, midwives, case managers, and case management support into primary care. And it turns out in a virtual platform, that's really phenomenal stuff to already have in place. Before COVID, in our primary care platform, we had already moved to about 70% of our interactions being virtual. So between text, email, phone, and video, about 70% of the touches in any day with people on primary care panels were already virtual. So moving to a 90 or 95% virtual platform was just an evolution of work already well developed over 20 years. So on that area, we've been participating with the IHI's Leadership Alliance and about 50 organizations nationally on a project called The Office Visit is a Dinosaur. And it's been exciting to share experiences of 20 years of development with other people who are trying to invent this stuff in the matter of weeks and months. So the idea that text, phone, email, video are completely legitimate ways to interact with people. We've been now sharing and teaching that with people literally all around the world who are struggling to figure out how to do it well. One of the worst temptations of this current crisis is going to be to move the current office visit-centric model to just a visit-centric in virtual platform model. So a lot of telemedicine is how do you make in video what you were doing in an exam room. And that should not be what we're trying to achieve. That type of a visit should be 20% or less of the way we interact with people. Instead, we need to figure out how to weave our services into their lives on their terms, when, where, and how it works best for them. Figuring out how to put our expertise and services into their home environment as they live their lives. That means text, video, phone, not just video visits. It means email. It means using a whole array of people. It means using behaviorists for primary interaction and support around anxiety and depression. It means using health educators and case managers to help with chronic disease encouragement, support, coaching, and chronic disease management. It means using pharmacists to help track lab values and changes on standing orders and medications. It means using dietitians to continue to exhort people to make differences in how they eat and how they nutritionally support optimal life. And all of that should just be woven in a continual way through reminders and texts and emails, and not just a video platform for a visit with a provider, like was the institution-centric way of doing office-based visits. So this is part of what we're pushing nationally and internationally. It's something we've worked on for 20 years with a great deal of success, and are very excited that the world is now interested in a whole different way than what it was before. In the last 3 years, we've added a bunch of specialists in primary care. So we've co-located physically in primary care, chronic pain specialty, physical therapy, palliative care, aging well, HIV, complex adult specialists, and pediatric specialists right into our primary care generalist platform. So they're there to help bring that specialized excellence into the generalist relationship-based platform, not be an alternative to refer or send people to. This has been really exciting, and another one of the things that this virtual platform allows. It's turned out that specialists all around the world are discovering if they can piggyback on the back of the generalist platform who know people, they can reduce by 80% the number of people they need to see in person, and they can become facilitative partnering consultants rather than destination center of excellence specialists. That's something we've done here for decades. The specialists that work for ANTHC and SCF have already been doing this in support of the regions and villages around the state, but with the Nuka system have been able to take it even a step further. The favorite example I like to share are the cardiologists who discovered long ago, if they play in this way, they can do 80% of their work virtually through the generalist platform, and then have plenty of time for more in-depth evaluation of the really complicated people they do actually need to see. COVID has accelerated this. It's just getting dabbled in other places, but it's something we've worked on for 10, 15 years and are excited to continue to share how extremely well that has worked as a platform. So specialists drawing expertise towards where the patient or customer owner already is in deep relationship with people they trust. Integration of behavioral health, addictions, mind and body together, separating that was the stupidest thing we ever did. It's really playing out well in this virtual environment, so that's also exciting. But it's not just the actual service delivery platform, but also the infrastructure support. So if you're going to start to have many people do things that aren't visit-based, you need to see what's happening. So you need an extremely capable data mall, a way to track chronic disease measures, screening, prevention, wellness, all of those things. You need reminders and stimulators to make sure you're staying on top of all the things that you need to stay on top of, and a platform where everyone can see what's going on and produce measurable results. So the fact we've had 15 years of our locally homegrown, super capable data mall has been fantastic. A lot of you have heard us talk about our 4 ovals, an annual planning tool, executive leadership experience, development of senior directors, and all of those many ways we've been growing people to lead our system, and that's also played off really well. In a system like this, where then work becomes home-based and virtual connectivity, you need everyone at all levels to have a sense of personal ownership and not just wait to be told by senior management what they should do. It's been phenomenal. The idea that we've had for decades now that we work on principles rather than rigid rules has paid off, because this flexibility to adapt to people in home environments and program after program to adapt every single week to changing external environments has been super important. At the center of all of this is the fact that we are Alaska Native customer-owned and customer-driven. So that means extensive consultations with tribal leaders, village leadership, local urban leadership, people with particular diagnoses and age groups, and particularly looking to our Elders Council and our tribal traditional leaders. We've always emphasized this big time. We spend anywhere from 20 to 30% in leadership and the active interaction with such leaders from the community. We take patient voice and customer ownership very seriously, but during this time, we've actually doubled down on that activity. It's even more important to use the leverage of leaders in all the different subsections of our community to look to them for what's working, what they want for their people, and how we can continually adapt our delivery system to what they tell us is working. They've also helped us connect to state, national leaders, and we've chased money from practically every source we can possibly chase it, resulting in pretty good financial survivability during this time when our clinical revenues have plummeted. We can talk more about personnel, the way we support them over time, but through a lot of creative use of CME and paid time off and so forth, we've at least at present not had to furlough anybody. It's a big challenge. Financially, it's all very challenging. We're requiring everyone to do all of their clinical CME, to use some of their PTO, and lots of creative ways to keep supporting the family of people we call family working alongside us here at SCF. So that's sort of the big level clinical platform. And then we've got a bunch more specific examples that I'll turn it over to Michelle and Donna.
So I'm going to talk a little bit, I'm going to build on what Doug was saying about some direct changes that we made at SCF in response to COVID-19. And in the beginning of the pandemic, which began early March for us, we looked at our emergency response plan, which is a very robust plan, and it covers things such as emergencies like fires and floods or earthquakes. As you all know, we had an earthquake a couple of years ago, when this is the plan that we followed in that situation. And that plan covers shorter term duration emergencies. And so it walks us through staffing, how we're going to respond to that, financial stuff, business operations. But what we noticed in the beginning, our president, CEO, and vice president leadership team, as they're looking through our emergency management plan, we noticed that this pandemic was going to last a longer duration of time, and we needed something a little bit more specific for the pandemic. And so a pandemic addendum was created that enhances our emergency management plan, and we plan to keep after this is over. Our pandemic addendum plan really walks us through our response levels as an organization for things such as critical staffing, so which employees are required to be on site, which employees could maybe telecommute, what operations are going to be critical to remain open based on the needs of the customer owners that we serve, and which can be done maybe remotely. And then what is the criteria we're using to assess when we're going to move levels? Our pandemic addendum has 3 levels as established by our president, CEO, and vice president leadership team. And so it very clearly outlines the criteria that will be used to move levels. And we used that in the very beginning to start when Donna had spoke earlier about the pandemic did not hit us all at once. We had slow cases. We had cases trickling in. And so we use this criteria to say, hey, as the case count increases, as health mandates increase, these are the levels we're going to move through. And we're going to have conversation real time every day about when we're going to be moving levels. So we use this pandemic addendum plan to move through those levels. We did that in conjunction with some of the leadership structure that our president and CEO has put in place through our senior directors team and our executive leadership program. So that was really effective because we already have those relationships in place and we have that structure in place. To add to that a little bit more, some of the direct response things that we did at SCF immediately and were able to shift to fairly smoothly because of our relationship-based care were things such as establishing a respiratory clinic through our primary care center. We did that very quickly, and we've had a great response from our community and the people that we serve for utilizing that respiratory clinic. We have an outdoor testing site. We stood up a donation center for personal protective equipment. We're actively monitoring our personal protective equipment supply and inventory, and quickly we identified the supply chain issue for PPE. And so we're monitoring daily our burn rates for all of those supply and incoming inventory. And we have a supply depot where we are centrally distributing supplies, PPE, as well as cleaning supplies. Some other unique things that we did is we identified through risk assessments we asked employees to self-identify whether or not they may be high-risk employees, and we had conversations about how we can support employees through that and what we can continue to do with that. We also identified where we could maybe shut down some or filter staff and employees through to have less high-touch surfaces for need for cleaning so that we could preserve those cleaning supplies. So we did that very quickly through our president, CEO, vice president leadership team, and then through our senior director team. And those messages would be communicated out through those structures. So it was very effective because we have these relationships in place. We were able to quickly implement and shift the way that we were doing things. Donna, would you like to add to that?
Yeah, I'd like to discuss collaborations. South Central Foundation really understands that collaborations are important, and we've always collaborated with many different groups of people, but during COVID, it was good that we already had these relationships created because we could expand what we were doing and needed to. So we worked with the state on many different issues. We also worked with hospitals, and we worked with the municipality of Anchorage to plan for COVID. For instance, there's 3 main hospitals in Anchorage, and we all came together and created a surge capacity plan, actually more than a plan. We actually got it set up so if we needed overflow from the hospitals, the 3 hospitals that would go into this area. So it was staffed by those 3 hospitals, and all the supplies are in place and ready to go. So it was a collaboration on a bigger scale than we've ever done before because we all had to participate and develop this plan and be ready to implement it immediately. So we did that, and then also we looked at the homeless population here in Anchorage and figured out what we were going to do around people who don't have homes. You know, how can we keep those individuals safe, and how can we test them, and how can we deliver the care that was needed? Again, it was a group effort. A lot of people worked on that and around housing and around testing. So that is still in place, actually. So we continue to work around that. There was a lot of different things that we did within our clinic. You heard about some of them from Michelle, but we actually began to look at how we were delivering care and how to continue to deliver care without a lot of people coming into the clinic. Of course, telemedicine, but there's other things that we did. So for instance, pharmacy, people need their medications, but we really encourage all of our customer owners to get their medicines through the mail. So to call in for their prescriptions early, and we would mail them to them without them coming in. We also extended some of those prescriptions so they wouldn't have to come in or run out of their medications early. If somebody really needed to be seen and they got a prescription, if at all possible, or if they were high risk, we would actually bring the medications to them in the room, or if they weren't, they didn't call in to get their prescriptions refilled and they're running out, we actually created a drive-through process so they could just come to our clinic and call a phone number, say they were there, and pick up their medications. That was very well received by our employees. We also had some drive-through testing in terms of blood draws that needed to be done. And we were also really worried about kids. We didn't want the immunizations to get behind, so we created a drive-up immunization process. Of course, we didn't give the immunizations in the car. We brought them into the building, but they didn't come through the main building. It was a side entrance, and they just drove up, came into the building, got their immunizations, got back in their car, and left. Again, that was very well received by all of our customer owners. I'll let Doug talk to you a little bit more about our personnel.
Thanks, Donna. So great examples. I've been very impressed by the creativity that's the mail out, come through the parking lot, tents, triage, blood draws through car windows, drop things off on people's porches. It's been truly amazing. For staff, we've moved to Michelle Aregood was also mentioning, we've moved to almost entirely working from home platforms where we can, and that's been somewhat of a struggle, but we've figured out technology, ways to do it. I think where we're going to end up in the end is learning that supporting people in their home environments is very desirable, but having our staff together in shared workspaces where they can see and talk and connect with each other and then support people in their home environments is going to work better than everyone working from their own home. Of course, there's going to be categories of staff that work extremely well from home. So like people in support of the electronic health records, some of the people doing some of the finance functions, and some of the health educators and other folks like that, grants management people. There's things that can continue being done from home or virtual workspaces pretty much forever. And we want to maintain and support as much of that as we can. But for direct clinical services, I think we're going to discover that we still like people in shared spaces that see and connect with each other, but still maintaining the patient or the customer owner in the home environment as much as possible. So we'll see where that all goes. The core statement here for clinical services is meeting them when, where, and how they want to be supported. So if individuals are responsible for their own health journey, their own health and well-being, their own priorities for their own personal lives, then how we weave seamlessly services into their lives becomes the most important thing we can do. So getting away from this institution-centric, professional-centric medical model and really transforming not just into virtualizing the visit, but instead figuring out using every modality. So how do we get use of the smartphone to feed back to us measurement parameters? So it turns out now you can do pulse and blood pressure and even EKGs and respiratory sounds and temperatures and weights and all kinds of things virtually through a smartphone. You can use video to show a lot of things visually. And once you have relationship and baseline data in hand, there's really not a lot of reason we have to make them come to us on our terms very often. So super excited to see how far we can take that and how far other people can take that. Our work nationally and internationally the last few months has been to push on this issue. Don't just virtualize the office visit. Actually rethink the entire platform using all the available technology and communication at your fingertips, and think of it as building a web of support, advice, cheerleading, and services into people's lives as they live their lives. So I think, there's just a couple other things to mention. Two other things I want to mention for sure around therapies. Especially, we run a very large, complicated child neurodevelopmental clinic. We call it Child and Family Developmental Services. It's a full merge of PT, OT, speech, and everything that goes with neuro rehab with child and adolescent psychiatry all in one space. So all children and youth who have particularly complicated challenges in their lives, it's one place where you can go for all of that to be addressed. As we've moved that onto a virtual platform, it's been very interesting. One of the most successful things we've done in this COVID that we weren't doing before was that move. And these parents of children who can be very difficult to get into a clinic environment, being able to stay in their home environment, and we adapt to them, and now doing our therapies on their terms in their space in their home where they live their lives is not just more convenient for the families, it's actually more effective therapy because it's done in the environment that they find themselves most of the time in which they live. So some of this stuff we never want to undo. We just have to figure out how to get the payers to pay us to do it in this way. And the family and children have been just wildly appreciative of doing that. The other thing I just want to mention is there's sort of become too easy to schedule meeting disease. And all across the world, it's been a problem, a complaint that comes up. It's so easy now to schedule a virtual meeting that people just schedule them willy-nilly, and you end up spending more time in meetings because they're so easy to call, and it doesn't involve getting people in the same room. So we have to figure out how to manage that so it doesn't get out of hand, but it does mean that we can have better and easier meetings. We can have full participation and attendance in meetings much easier. As I mentioned earlier, the no-show rate for visit appointments pretty much goes to zero. It turns out if you don't force people to take off of work, get transportation, and come to us, they don't have reasons to not show up. And so our no-show rate's gone to almost zero for pretty much all of our clinical activities, which further reinforces the fact that we've created most of the problems in modern healthcare, not the patients or customer owners. And it's high time then we reject things that don't work for the patient and customer owners and instead comply with them and adapt to them. So Gil, I think we're going to turn it back to you and see what kind of questions you've been accumulating for us to spend our last 20 minutes discussing.
Great. Thank you, Doug and Donna and Michelle. Some great information for all of our participants today. Gotten lots of great questions, and I'll start with the most recent one because it's the one that's on my screen right now. And it says, long term, do you see the move to telehealth having an effect on the way the future primary care centers are designed? If so, how?
Doug, I'll jump in first. We have done now consulting and advising literally all over the world. And it's been amazing to me that even in areas that have had single payer systems for decades, that they still rely on the doctor-centric medical office clinic visit model. So there's two problems in healthcare. One is the money and what it pays for, but the other is the pervasiveness of the medical model, the doctor-centric, institution-centric, you must come to us on our terms, physician-centric model. And COVID has all of a sudden, in all payer environments, made us move to this focus on them where they live and how to get services to them instead of making them come to us. And this is phenomenal. This needs to stay permanently. In procedure-based things, people need to come and have a procedure done. But in cognitive-based things, so almost all of primary care and most of the cognitive specialties ought to permanently move towards treating, supporting, interacting, encouraging, coaching, advising, cheerleading people in their home environments on their terms. So I think the people who need to lead the way are people for whom this is not a financial barrier. So single payer systems, vertically integrated systems, where they can do this without moving into financial ruin, need to do it and prove to everyone in the world that it is just plain a better way of doing it. COVID's already shown this in spades over and over multiple places. So we just need to make it permanent. Some places that will require changes in payment methodology, and it certainly needs to drive changes in reimbursement, but we need to reject this decades-old professional medical-centric way of doing business. I also mentioned therapies, doing therapies in home environments where people live, huge advantages to doing that. There's been great success in behavioral health, mental health, and addictions. It turns out that the best way to destigmatize mental health and addictions is to do it online, because no one can see you going to the clinic. You don't have to tell people you're taking off of work to go have your therapy appointment. It's all completely destigmatized. It also allows us to respond in the moment when people are ready to try and make a change. So massive improvements there. I don't know, more things on the list?
I just wanted to add that all of our customer owners are empaneled to teams, and so they know the teams, and so actually having that relationship built already helps with this telemedicine. So all of our teams just about, we're delivering, I don't know, but 3/4 of care through telemedicine during this time, and it's just now that we're beginning to open up more. But it's worked well. You know, our customer owners have loved it, and they've adapted to it extremely well. They prefer the phone, I would have to say, but they've also done Zoom and Microsoft Teams and other platforms that have worked. So think about that. So if somebody is at work and they have an appointment, they can say, I'm going to take a 20-minute break, and then go out to the car or go into another room and actually have an appointment, then go back to work immediately. So it doesn't take time. You don't have to drive there. You don't have to check in. You don't have to do all of this stuff that adds to the time of a visit. You can actually do it quickly. And so I think for that reason, our customer owners are liking it. They also like the face-to-face. I think, I know it's virtual, but people are getting used to virtual stuff. And so it works well. They're enjoying it, and they feel like they are actually getting more face-to-face time. And I'm actually thinking it's because, like, right now I'm looking at all of you and you can see me and I'm talking to you, and that's how it is when we're delivering care. You're actually looking at the person and having this conversation. And I think it's well received and works extremely well.
Thank you both. So we got another couple of questions that kind of, I think, are a theme here. What info is being taken into account, or what data is being taken into account for reopening, and who evaluates that data to make sometimes very quick decisions?
I can go ahead and jump in there. So we established a reopening plan. And part of that plan, we look at the state of Alaska health mandates. We look at the Centers for Disease Control and Prevention guidances, as well as other health official guidances. We look at SCF's risk mitigating techniques, such as ability to socially isolate, universal masking, our cleaning supply inventory, to determine our phases and moving forward in our phases. We take into account the needs of our customer owners during each of those phases. We also take into account how many employees can feasibly remain teleworking, and the goal is to be able to prevent or to reduce the risk of physical interaction, right? And so decrease that as much as possible with social distancing. And at each phase of reopening, so our leadership team, our vice president leadership team, and our president CEO meet 3 times a week to make real-time decisions, to look at data. They're also given data every single day that they're looking at, and 3 times a week they come together for a meeting and discuss that data, look at it, make real-time decisions. Some of the data that they're looking at are the daily case counts, the hospital utilization rates, the bed counts, those things, the death rates. We have a very low death rate in Alaska. We're fortunate for that right now. And so that information is reviewed, and we're looking at if we can continue on the reopening plan, which I mentioned earlier has 3 phases, or if we should pause or scale back.
So data is really important to us, and we use data in a lot of different ways. Yes, it's very important to leadership because they make decisions around this, but it's also very important for on-the-ground providers and what they're doing. One of the things that our providers recognized pretty quickly is that there was the potential to get a lot of people who had a positive test, and they wanted to know who those individuals were, because they wanted a quick way of looking so that they could make certain that they didn't get lost, so to speak, and that they could check in with them every couple of days to make certain their symptoms weren't getting worse. So we use it in a variety of ways.
Here's another question. What do you think will change long-term because of the pandemic? I think we've spoken to some of this through the presentation, but I think it's a great question. What do you think will change long-term as a result of this pandemic?
Just say one thing that I really appreciate about SCF working here is one project that we're working on currently is compiling a list through from across the organization of things that we feel are going well and that are working well that we want to continue after the pandemic is over. And so though that hasn't been fully compiled yet, our leadership team is thinking about that right now during the pandemic. What is working well and what do we want to continue? So I really appreciate that working here, that we're already starting to think of that and innovate and think about ways that we can do things differently.
It has to do a lot with what our customers are telling us also. So, you know, Doug was talking about our one program that's being, well, we got several programs that they really like the telemedicine and they're working well. But like our customer owners really love the drive-up pharmacy. You know, should we continue that? Probably. You know, we need to figure out how to do that, because right now we have a tent and there's something called winter here in Alaska that may put a little bit of a damper on that. But how can we be innovative around that, and how can we figure out to deliver these services so that our customer owners are happy with that service and can plan around it? So like with one of the things we would do after things calm down a bit is talk with our customer owners and ask them, what is it that you want? I mean, they're already giving us lots of feedback, so we're taking that into consideration. We're also looking at outcomes during this time to figure out things that are actually working better than before COVID. So we're taking that into consideration too and making those plans.
And I would just also add that we're looking at things that maybe are being done outside of healthcare system to see how we can implement those inside of a healthcare system. An example would be in our health education department, they have a little store where there are supplements and healthy foods. And so they've implemented a process by which customer owners can call and get online and order stuff from that store and do curbside pickup, just like you might at a grocery store. And so that is one thing that I'm imagining may stay after this is over.
Yeah, so places that are not visit revenue based. So unfortunately, over 50% of our revenue is based on visit based payments, and ideally that'll change and improve. And we're certainly we're joining with lots of people lobbying both at the state and the national level for payment reform to allow us to continue to do the right thing along with everyone else instead of what money drives. But especially those areas that are not direct visit revenue based, so health education, the things from the store, a lot of the therapies where revenue is not directly tied to the activity very much. All of those we hope can remain way more virtual. I think we'll be way more supportive of remote working and things like the EHR record support people, a lot of the data management people and so forth that could work remotely. We've been a little hesitant to allow a lot of remote working, but I think we'll be more open to that in the future. And then just lots of the therapies and so forth we already mentioned. I do think one of the more dramatic changes, both nationally and internationally, is this destigmatizing of mental behavioral health and addictions work and being able to get direct access in real time immediately during the window of opportunity. So huge opportunities there.
Well, that's a great segue to our next question, which is how are you addressing the toll on mental health during lockdown? I'm assuming that this individual is asking about the toll on employees and staff, but I think we could potentially speak to how we're helping support customer owners as well.
There's a variety of things that we're doing. We actually have some sessions for our employees, and they were actually, I believe they were daily sessions for a while. There was a whole bunch. I think they backed off a little bit to 3 times a week, but our employees really liked them. There was lots of good feedback with it. It was just people getting together with Zoom and having discussions and talking about stress relief and being able to talk about what's going on in their lives. We also realized there was a lot of issues like when the schools closed down and daycares closed down and all of us and our employees were no longer here, and so they were home with their kids, but we were expecting them to work from home and all those issues that go with that. So we figured out how to do that effectively and offered lots of support and tips on how to do that. We also gave lots of tips in terms of activities at home. One of our employees actually went around and delivered just a ton of activities to families with kids. You know, it was, again, the drop-off service, driving up to somebody's home and dropping this off and say, you know, here's activities for your kids, enjoy, and just, you know, driving off. So there was a lot of support for our employees and just, I think actually some of the virtual meetings helped support all of us because we were all in a new situation. And so, you know, part of what we do at Southcentral Foundation and with any of our meetings is to do a check-in. So it allows people to actually say what's going on and share with people that they know.
The example Donna just gave of materials for families and children to do in their home dropped off on their porches, just to mention the cost of the employee to do all the drop-off, driving, and delivery, and the cost of all the materials development was all covered by an early childhood grant we had already in place. So we talked to the grantor, said, hey, we'd like to develop these materials, deliver them, help with early childhood and family wellness, and decrease screen time and violence in families and so forth towards building up their positive activity time. And the grantor was happy to make that adjustment, and we spent a ton of their money putting that in place. So just an encouragement, look to your grants and grantors during this time to get creative on how you can spend the money to create health and wellness with people stuck in their home environments.
Another question that came up, and we've got a couple more questions, and then I think we'll wrap up with another question here is, how are you keeping everyone on the same page with such a large staff? We have over 2,500 employees, so it's a great question.
So we have lots of different ways that we're doing that we're communicating out. We have a newsletter that we put out with lots of different information in it. But since early March, we've been doing a thing that we call daily updates. And so we publish that through our intranet every single day, and that provides updates on daily case counts. It provides updates on changes to operations. It provides updates to temporary procedures that have been put in place. It provides updates on how SCF is reacting and responding to health mandates and guidances from the CDC. And so we publish that every single day that goes out. We're also really committed to transparency. And so we decided early on that we would notify employees if there was an active case on our campus. And so we send that out when that occurs, that information in a general way so that employees feel informed and aware. We have a manager's update that goes out with higher level information, and that's disseminated through our senior directors group with more details of procedures that they can share with their staff in their departments. And then we have daily meetings. We're encouraged to have our daily check-ins still with all of our employees so that we're having that face-to-face and that phone call meeting or that Zoom meeting, still that personal connection with the people that we work with every day.
So we have all of those systems in place, but I would also have to say that sometimes that wasn't always easy. So we tried to make certain that all of our leadership was on the same page, and, like the managers and the supervisors and the frontline people, so that they were aware of what's going on so that they could actually answer the questions that other people had. But part of the problem is we were learning as we were going, and we were getting different mandates, and more knowledge was put out there. CDC was changing its recommendations. We were following state recommendations, and so it's difficult at times because you would put out something one day and it would change the next day. And so the best thing that we found is to actually be very transparent about that too. Just say, this changed, and here was a thinking behind it, and that's why it changed. And it also, by doing that, it also created a lot of trust because our employees realized that we were keeping up with things, and we were trying to move as quickly as we could. With all the changes. There was times where there would be something that we had created in the morning, we were planning on sending it out in the afternoon, and then it would change in the afternoon, so we would have to change it again before we sent it out. But we were just transparent about it and made certain that as many people as possible were aware of whatever it was we were rolling out.
Right, thank you. And one final question here. There's definitely an increase in the number of virtual visits with providers using video, using telephone. What's the role of a medical assistant in this kind of changing world of care delivery?
That was one thing that was kind of that we had to be innovative around. So we actually had some of our medical assistants over at the drive-in sites. There was 2 in town here. We had one on campus and one off campus, and some of our medical assistants were over there also doing the testing for the community. We also had people who, would do the screening at the front doors, and they would help with that. We still need medical assistance within our clinic because we had the respiratory clinic, and we also had an urgent care clinic, and we also have a fast track too, which is part of the emergency room. So there were some roles, but we did have to be innovative and look at other ways that medical assistance could be employed during this time.
All right. Well, I'm checking to see if we have any last minute questions. I'm not seeing any in the Q&A. Are there any final thoughts that our panelists would like to share before we wrap up?
As I said earlier, there is no question that this COVID pandemic has done a huge amount of destructive things. Hospitalizations, deaths, people with long-term medical disability from impact on their lungs and other organ systems. huge destruction of economies, employment, financial security. There's no question this is a horribly destructive time and pandemic. However, for healthcare delivery services, this is the opportunity of our entire professional lives to try to recraft healthcare into something that works for the people for whom we exist. We do not exist to make the professionals happy or for their convenience or for the efficiency and use of doctors. We exist to help support people on their health journeys. And this is our moment in history to really do healthcare transformation work and not just nibble around at the edges, but to take this worldwide innovation lab of the last 2 months and really understand what's working and not working and how to change permanently healthcare into something that's based on what people need and want, when, where, and how they want it, living their lives in their homes with our support. We need to not just move the platform of what exists into a virtual space. We need to rethink, how do we use tracking technology, communication technology, cheerleading support, meeting people in real time where they are with needs that they want, and make ourselves into the service industry supporting people on their health journey that we were always meant to be. We exist for them. It's time we quit making them conform to our needs and use this as the lever point for transformational change.
Thank you so much, Dr. Eby, Dr. Galbreath. Michelle, thank you all for sharing with our attendees this afternoon. We are going to wrap up now. We'll be doing these fireside chats several times over the coming weeks. There is also our virtual Nuka conference, which will be coming up July 27th through the 31st. If you want to find out more about any of our training opportunities or consulting opportunities, just go to scfnuka.com. Again, thank you to all of our panelists. Thank you to our attendees today. Really hope that this has been helpful for you, and we are very grateful for you allowing us to spend some time with you. You'll see a slide on the screen now that shows all of our upcoming events with all of our contact information. We're going to leave this up for a couple of minutes so you have time to access this. Please don't hesitate to reach out if you have any questions or want to find out more about the Nuka system of care. Thanks to everyone who was involved today. We'll see you next time. Take care.